Good morning, everybody. It's a pleasure to moderate this joint ISMICS session over here today. We've just been asked, because of the translation system, whenever you're speaking into the microphone, to not speak too fast, and I'll try and remember to do that as well. And this is not Dr. Jens Ruckert. I think he's still on the way. So this is Dr. Calvin Ng, who'll be stepping in. And so the first talk, we're actually going to be doing half cardiac and half thoracic. And I'd like to invite Dr. Anson Chung, who's the current president of ISMICS, and he's going to just talk a little bit about ISMICS and transcatheter mitral therapies.
Thank you. Thanks. Thank you. So, well, thank you for attending our session here. We'd like to thank you, Chairman Fernando and Ng, I guess. Yes. First, I'd like to introduce ISMICS to all of you, and then I will go on to my talk on transcatheter mitral valve repair and replacement. So I just want to tell you about ISMICS. ISMICS is, stands for International Society for Minimally Invasive Cardiothoracic Surgery, and we were founded in 1997. We are truly an international society with a lot of members, 900 members now, with over 42 countries. And our direction, our mission is mainly to take a leadership role and also to promote minimally invasive technique in both cardiothoracic surgery and in better treating our patients. We also, in addition, we do a consensus statement every year in different topic in the minimally invasive area to guide and hopefully, again, leadership role to further our understanding in this area. Could not advance. Okay. I could not advance my slides yet. Oh, there we go. So in addition to our annual meeting, usually happening in the end of May or first part of June, we also co-sponsor different meetings around the globe, including this meeting here in Astana. We have sponsored, co-sponsored meeting in North America, South America, in Asia, and we haven't gone to Australia nor Antarctica yet, but we'll hopefully one day we'll go there. Happy slow response to the forward. There we go. And this is some of the examples of some of those consensus statements we publish every year. And later on, our past president, Dr. Francis here, Fernandez, will actually will deliver one of the consensus statement. In addition, we have an official journal for our society, it's the Innovations. It has been indexed, and in upcoming months, and hopefully we'll get an impact factor in addition to that. And our volume of publication in the Innovations has increased dramatically for the past few years since we have be indexed. We will welcome you to submit it to our journal. And also, in addition, for our annual meeting, you can submit your manuscript for additional awards. And it's quite a handsome amount of money that actually for the best manuscript published in the journal, which is $1,000 US. And there we go. So just go back to the annual meeting. The meeting will be in my hometown, the beautiful Vancouver, this coming June, from June 13th to June 16th in Vancouver, right on the water. And if you haven't been to British Columbia, and I will encourage you to come and join us. So I'm going to go to now my main topic of the day. I'm going to talk about catheter-based mitral valve interventions. So just before we go there, I just want to show of hands, how many of you are involved in catheter-based mitral interventions here? So we got one here. Anyone else? No. So I guess it's quite a new topic then. Hopefully we provoke some discussions here. So those are my disclosures. It's a bit really slow. Is it because the battery is running out here? There you go. There we go. So just talk about the incidence or prevalence of valvular heart disease, and we can see that on the panel here. They're showing that as age goes up, the number of aortic disease increases. Actually, the estimated mitral valve disease among the elderly is almost twofold compared to aortic. If you see what happened to how we treat aortic stenosis in our elderly, we've gone from surgery. Now a lot of patients will be done by a TAVR, a catheter-based technology. Mitral, we eventually get to there. And mitral valve disease, we are definitely undertreated, just like how we undertreated aortic stenosis in the past. We have several studies in US and also in Europe estimated that only 2% of our patients that with symptomatic mitral disease are actually underwent surgical interventions. All the other 98%, either half of those patients, almost half of them were refused due to either they're too old, they have too many comorbidities, and they have other reason. The surgeon or the cardiologist have never actually referred the patient to the surgeon or saw them and say that this is not a good candidate for surgery. So we only operate on 2% of them, very little. So definitely that is a population that's being undertreated and under-referred. So, in terms of the patient that actually got to the surgeon, we say that they're good surgical candidate, and they actually had very good outcome, including very low mortality, 30-day mortality, and very good long-term outcome, especially in the repair group, and they benefit from it by improving their symptoms. They have less symptomatic. However, I have to argue that that patient group are very highly selected. We're only taking 2% of those patients that got to that. So the result, of course, is very good because we selected them. Or you can congratulate yourself that you had picked up the right patient to operate on. However, that is mostly on the patient in the degenerative mitral regurg group. In terms of the patient with functional mitral regurg, either from ischemic cardiomyopathy or dilated cardiomyopathy, the outcomes are not as good. Even doesn't matter if it's repair or replacement, the mortality is quite high. So in that particular group, we just don't know what to do with them. And there we go. So I'll give you examples of a patient who has this, what I call unmet need. This is a patient of mine, a 39-year-old gentleman who came in with ejection fraction of 20% with a very large ventricle. The LV dimension is 94 millimeter. It's bigger than a football. And with severe functional mitral regurgitation with dilated cardiomyopathy. Have multiple admissions for inotropes for heart failure. And was referred to me for heart transplantation, and you probably needing an LVAD as a bridge to transplant. So you can see that on the echo there showing that it's torrential mitral regurgitation. Well, what do we do with this patient? Well, those are the options. Either we continue medical therapy, which we exhausted. He's been on inotropes 2 or 3 times in hospital, so really medical therapy is out of the question. He had a narrow QRS complex, so he's not a candidate for CRT, for the IV pacing. So could we do mitral surgery in this patient? Or should we just go directly for transplantation? Or should we put LVAD in as a bridge to transplant? Or should we do something else, such as a catheter-based mitral surgery? So just put up your hand now. We think the patient, you will operate on this particular patient. Anyone here? I guess not. How about cardiac transplantation? We think this is a good transplant candidate. He doesn't smoke, doesn't drink, good family support. No transplant either? Okay, how about LVAD? Anyone will go for LVAD here? Wow. Huh? You're both thoracic surgeons. Yeah, I know, sorry. Yeah. Which, you would? Who is not a thoracic surgeon? It's all thoracic surgeons. Okay, all right. Okay, all right. So anyway, so, one of the things that we could potentially do is a catheter-based technology is the mitral clip. So this is a transfemoral venous transeptal approach to actually put a clip in the mitral valve to make it a 2-leaflet become a 2-orifice valve to decrease mitral regurgitation. So how this works is, and is based on the theory of alveolar stitch, which is from a surgeon from Milan that actually pioneered that particular technique. So we actually have a randomized trial of this particular technology. We randomize patient with mitral clip versus a mitral valve repair and surgically, and then we actually look at the result over time. Now we have 4 years result in that particular group. We show that mitral clip had very good improvement in the mitral regurgitation, and it was pretty durable over 4 years. Now, it is definitely, well, they call it more effective than surgery, only because patients require less transfusion. So really, I wouldn't say that that is actually true conclusion of that particular study, but they claim that. This is how cardiologists usually claim, to find a way to make them feel better. Now, the problem with mitral clip is that the mitral regurgitation grade 4 being the highest grade, 3 is a moderate severe, and then 2 is a mild. What happened is that the grade decreases, but it's not durable. What happened is a lot of patients by 1 year had already had worsening of their mitral regurgitation. So it works for a short time, but it doesn't last very long. The other problem is that if you have recurrent mitral regurgitation, the survival lower. You can see that if you had developed, go back. Do you think you can get me another clicker that is a bit, I think the battery is not working. But anyway, so if you have recurrent mitral regurgitation, your survival decreases down to 50%. And the, it's not working. Yeah, right. So the other thing, the limitation of mitral clip is that if your mitral valve area is very small to begin with, if you clip it, you will actually get mitral stenosis. And the other thing is that if you have a big flail segment, it's not going to work. And also that if your patient have very poor imaging, you can't really do that implant. I can advance my slide. Yeah, very good. So there is now other system that could potentially do that. It's a system called Pascal system, which has a better grasp, and it's by Edwards. We just show you a case that we just recently do with this particular new system, and show that it's a better, a better system of effectively grasping the leaflet, which is right here. I can show you. So this is a patient with mitral regurgitation. You can see with eccentric jet, with a retracted posterior leaflet, and right here, and then with eccentric jet with the mitral regurgitation. Then we put 2 clips in. It decreases the mitral regurgitation grade from severe down to mild. Still not completely getting rid of completely all the regurgitation. If someone could advance it for me, next slide, please, thank you. Another system is that we could put also a ring. Well, it's not a ring, it's probably we call that a restriction system that into the coronary sinus. That coronary sinus is actually a very close relationship with the posterior mitral annulus. You can shrink the annulus and potentially lower the regurgitation grade. So this is a system already been CE marked, and it's called the carry-on system. Next slide, please. And then also that it showed that in the Titan 2 trial that in 12 months, the regurgitation grade also decreases over time. And patients also feel better with decrease in the NYHA classes. Next slide, please. Very good. I'm just going to skip ahead. Next slide. It also showed that the LV dimension also lower as time goes with the system. So showing that there's sometimes some of reverse remodeling in the ventricle. The next system I'm going to show you, if the slide advance. Next, please. And next. So the other system is called cardioband. This is also transfemoral transeptal system. What you do is trying to mimic a posterior annuloplasty ring. They put screws actually into the annulus, and then we cinch the annulus and lower the dimension, and eventually get the regurgitation grade lower. Next slide, please. And in this particular study, again, you show that the dimension of the mitral annulus decreases with this particular procedure. Next, please. And next again, thanks. Next slide. Thank you. So a lot of, this is the repair could work for some patients. But when you actually trying to enter this patient into a trial or into using it in the patient, we exclude a lot of these patients. So, wow, why can't we just replace the valve? Actually, we've proven that replacement is actually very good. We can eliminate the mitral regurgitation completely. So, can you push next? So why can't we just deliver the valve like TAVR through a wire? However, the mitral valve is a bit more complicated because it's not circular, it's a saddle D shape. And in addition, there's a lot of other structures surrounding the mitral valve, the aortic valve, the left ventricle outflow tract, and also the conduction system around it also is a problem. And fixating a valve onto a object that is flexible, which is like the mitral valve. In the aortic stenosis, you have calcium, so you can just use radial force to fix the valve. We can't really do that with mitral. Next slide, please. So, however, the engineering are very smart. They actually now have more than 25 devices now out in different development phase that you could actually anchor the valve into the mitral area. Next slide, please. I'm going to show you a few of these that already have undergone first-in-man clinical use. Next, please. Very good. This is just a timeline showing that this 7 different valves that have actually been implanted since 2012. I'm going to go through some of those with you. Please, next slide. So the first device is the cardiac AQ device, and the first implanted in 2012 by Lars Swanegaard in Denmark. And what it does is actually apical delivery, actually initially was transeptal, transfemoral, now it's become a modified transapical system. The company was acquired by Edwards for $400 million, and it's a fair amount of money in 2015. Next slide, please. And this is how it's implanted apically. So you put under echo and fluoroscopic guidance, you put the valve across the mitral valve, and it has hooks in the ventricular portion of this device. It grasps the leaflet and the annulus and the caudae as to fixate the valve onto the mitral annulus. Next slide, please. And they did the first case back in 2012. Unfortunately, the patient did die in a patient that very extremely ill. And since then, they have done 13 cases worldwide. Unfortunately, the mortality is quite high, with 62% in very ill patients. So currently, there's a trial going on in Europe, US, and Canada, to try to find out if this is actually a useful device. Next. And the other device is called the Tendyne. What it is another apical device that could deliver through the left ventricle apex. And the first case was done in 2013 in Australia, initially in Paraguay and then now in Australia. And the company is acquired by Abbott for $250 million. Next. So how this device works is that after you put it into the mitral area, you pull the device towards the ventricle, and you put a fixation, a tether, actually a strain on the device, preventing it from ejecting into the left atrium. This device is actually quite good and quite easy to use. And they did the first feasibility trial in Australia and in US with 30 patients, with a risk score of STS score of 7.3%, with 93% success rate of implanting this device. Only one patient died of non-cardiac cause. So it's quite good result. And actually also show that the patient has really no leak through this valve, and also show reverse remodeling with improvement in LV function. Next, please. And another device is the Fortis. This is a device by Edwards. This is how it works is that you go apical, you go in through the mitral valve, and you expand 2 petals. These 2 petals grasp onto the anterior leaflet and posterior leaflet, and you captures it. Once you captured it, you push the whole device up into the atrium. You can see that is now how you grasp it, and then you release the rest of the device. And this is, the first was done in 2014 in London by the Vinit Papat. And subsequently, we have done, that's done 13 cases worldwide with, unfortunately, again, high mortality. And this initially was into a trial, but they find that the valve actually formed both. So they actually stopped the trial and suspended the program. Next, please. And then the another device is the Interpret device, and it's formally called 12, and it's acquired by the Medtronic. And this device, next slide, please, it had a dual stand device. This is almost like a wine cork. What is it? It's basically plug or wedge itself into the mitral annulus to fixate. Next slide, please. And this is how it works. You put it into the atrium, you expand the valve. It's self-expanding, so you don't need to blow it with a balloon. And you just wedge, we're using radial force and wedge itself into the annulus. And they did the initial trial. Now it's presented with 38 cases with 95% success rate in implanting the valve. However, still high mortality in this functional mitral regurg group with almost 30% people die within the first 30 days. And the remaining patient who survived actually had 80% improvement in the symptoms. Next. Next, please. Very good. I'm going to skip over this device. Next, yeah. Next slide, please. So this is the device, I'm just going quickly, is that they had a ring that put in around the subvalvular apparatus, and then you put a valve within a ring to fixate it. You know, it sounds very easy how to do it, but it would take hours to try to put a ring around it because the cordite and the leaflet are very complicated. You can't really put a wire across it. It takes hours to do. And however, there are some several successful cases being done now. Initially was done in Munich, and subsequently a few cases done in Italy. Next. And no current result of their clinical results is being published. Another device is called the Chase-on device, and it's very similar. Again, it's two components. The first component is grafts onto the mitral leaflet, and it becomes a docking station, and then they put a valve inside the docking station. Next. And this device was first implanted in 2016 in New York, and then now it's going for a clinical trial. And also the company was just recently be acquired by Livalova. Next, please. So what happened to our patient that I presented earlier? So we didn't know what to do with them. So, well, we say that maybe we should do something, maybe delay his transplant or LVAD. So we decided send him for mitral clip. So this is the procedure. Next. So, however, after we apply one single clip to the patient, we haven't released the clip, we just applied it, he still has torrential severe mitral regurgitation. So we know that this patient would not do well with the mitral clip. So we took the patient off the table. Next. And then we implanted one of this valve. So this is a valve that's actually the engineer and manufacturer in Vancouver, where I work. And we implanted this device in 2014. So this particular patient is the third patient that we implanted this device, and we have done 34 cases so far with mortality of 12%. Next, please. How this device works is actually, I'll show you actual implant video. So you can see this patient with a big ventricle, severe mitral regurgitation. We identify the apex. We make a tiny little incision in the apex. We'll put a wire through the apex into the left atrium. And this device just go directly over the guide wire through the mitral valve. This majority of this procedure is done under echo guidance. First, we expand the atrial portion of this device. It's self-expanding, so you just have to turn the knob, expand it. And then since this device is D-shaped, so you can rotate it to the native anatomy of the annulus. And can you go back, please? The video is not finished. Can you go back, please? Very good. Can you let the video run? Just go back one more slide and then go forward, and the video will run. Okay, that's good. Excellent. Great. So again, there was apical incision, and there was this type of patient. are quite well tolerating the procedure. We do not have to do lung isolation for the incision because the lung, we are actually in the 6 intercostal space majority of the time, and the lung is not in the way at all. And we, in general, extubate the patient on the table after the procedure. So again, we put the device in apically, expand the atrial portion of the device, it's self-expanding with light tunnel technology. Once the atrial portion is expanded under echo-guided, we rotate the device to the native anatomy. Once that is done, we pull the device back down to the ventricle. Initially, we pace the patient to decrease the ejection to implant this device. We have stopped doing that. You actually do not have to do that. Once you identify you have a good seating, you just release the ventricular portion. The taps anchor onto the annulus, and this is you just release the valve and show that very good hemodynamic with this valve. And there's no leak whatsoever. You can see on the echo showing that the device completely eliminated the regurgitation in this particular patient. And then once we're done, we remove the deaderifying system and basically close the ventricle with the 2 sutures. Next, please. So this is the patient that had, that been on inotropes for so long. He actually went back home, have never been admitted to hospital again with heart failure. And this is his echo at 18 months. Now, ejection fraction is still very poor, but he felt better from NYJ class 4 down to NYJ class 2. Next slide, please. And this is what happened is that the patient with dilated cardiomyopathy, even though they felt better, eventually this patient got worse. At 22 months, he came back with class 4 heart failure. And I implanted an LVAD in him. And eventually, 6 months later, after the LVAD, I transplanted him. So this is the explanted, his heart that I explanted, showing the devices had grown into the ventricle quite nicely with absolutely no leak whatsoever, and the leaflets are intact with no fracture of the device. Next, please. So how we treat this type of patient now is that we take a multidisciplinary approach to it. It's no different from when you do thoracic surgery that you have let's say do a tumor, you have a tumor board meeting. You have your surgeon, a respirologist, oncologist, and other specialty. In this type of patient, we involve the cardiologist, echo guy, CT imaging is very important for pre-op planning, nursing, cardiac surgeon, and also now very important is heart failure cardiologist involved in this particular patient. Next slide, please. And then we actually decided what to do with the patient. Not everyone will actually eventually get to a procedure. Some of them will require medical therapy, some go for transplant, and some of them we will say that is really we can't help this patient. We might be palliation. Next, please. So in summary, there's definitely a unmet need in the mitral valve surgery therapy. The mitral valve is a very complex structure. It requires a multidisciplinary approach to it. Repair is effective in some patients. However, that replacement will probably eventually be the route for a patient that with a end-stage functional mitral regurgitation. So this is all different technology is in a toolbox to treat a very difficult type of patient. Next slide, please. And thank you. Very good. Next.
Any questions from the audience? So I had a question with the clips that you place.
Yes.
I mean, as opposed to a valve, which I'm guessing gets fixated, what's the risk of those clips migrating down either earlier on or down the road, and how often do you see like a late embolization?
Right. So that's right. So those clips are quite secure, and we do see clips that had dehisced. That means that it had detached one of the anchor. So what happens is that you have recurrent or mitral regurgitation. So actual embolization of a clip is almost unheard of, and unless it's a technical issues. Usually it happens immediately, not late. But tearing out of a clip happens, unfortunately, more often than we would like.
Yeah. And then in that last case, I mean, the valve obviously was beautiful in the way it worked in that patient, and you're doing this in end-stage patients. With those kinds of success, what's any thoughts on moving that to a healthier population?
Yeah, I think that is the key. I think is that we are, you saw the result of quite poor fertility mortality is because we're doing on the sickest of the sick. And I think once you get to a patient who have better ejection fraction, and get them early, you will have a better result. And I think the key is not to, for functional mitral regurgitation, is that you are trying to improve the quality of life of the patient or delaying their transplant. You're not going to improve the mortality really, because the disease is in the ventricle. You're only fixing a portion of the problem. We have no technology of fixing the ventricle. Cell therapy doesn't really work. LVAD will, temporizing it, sometimes for destination therapy, and transplantation, again, is trading a disease to immunosuppression. So we don't really have a cure for ventricular dysfunction at the moment. Yeah. Right. Thank you.
Now it's my privilege to announce the next presentation. It's by Chris Fernando, and the topic is sublobular resection versus SBRT ablation for high-risk patients with lung cancer. Very actual topic.
All right, so I'm going to be talking about sublobar resection versus SABR, or SBRT, which is the other term, stereotactic body radiation therapy. SABR is just the newer word. And this is really an important question. So when I look at stage 1 lung cancer, I think of the standard risk operable patients who are treated with lobectomy. Then the high risk but still operable patients who are treated with a wedge or a segmental resection. And then we have the truly medically inoperable who are treated with either SBRT or radiofrequency ablation. Now, focusing on SBRT, initial studies looked at medically inoperable patients. These tended to be single-center or multi-center studies, but they were all single-arm. And they established feasibility and safety, and they also established dosimetry for peripheral tumors. The current questions are, can we extend the use of SABR to high-risk operable patients, i.e. to patients who are treated with a segment or a wedge? And can we also use this in lobectomy candidates, which I don't think is a good answer. And also, the radiation oncologists are looking at this in patients with lung metastasis. They're also looking at optimizing dosimetry for central tumors. Now, with sublobar resection, the main concern has been increased local recurrence rate compared to lobectomy. And in many ways, this is because of the randomized study by Ginsberg in 1995 from the Lung Cancer Study Group that showed a 3-fold increase in local recurrence rate with sublobar resection. And for this reason, this has led, the current standard is preferential use of sublobar resection for high-risk patients that we don't think can tolerate a lobectomy. However, again, that standard is now being challenged again for tumors that are 2 centimeters or less in size. And there have been 2 large randomized trials that have been recently completed, one in Japan and one in North America. And the results will be coming through in the next 3 to 4 years. So we may see that for these smaller tumors that segmentectomy will become a standard of care for these smaller tumors. Now, when we look at comparing stereotactic body radiation therapy to sublobar resection, there's a lot of things that are perpetuated in the literature. One advantage of SBRT that's often quoted is that local control is similar or even better than lobectomy. But if you look at the studies, the definitions of local control are different between the 2 studies. And depending on how you define it, you can get a different answer. Another problem when you look at SABR studies is that these often include patients that have no tissue diagnosis. So we don't truly know whether we're dealing with cancer or not. And when people quote studies and results in patients that do not have a cancer diagnosis, that's a problem if you're trying to compare therapies. Another issue is when recurrence occurs. Usually in the radiation oncology literature, they limit this to CT scan findings only. They rarely use PET scan, and they don't routinely use biopsy. So these are all issues. Now, there have been several studies from single institutions that seem to suggest that radiation might do better. Most of those studies have come from radiation oncologists, and a proportion of those studies have included patients without a diagnosis. But these are some national registry studies. These involve thousands of patients, and these have been propensity matched. And when you look at these, the surgery has done better than surgery when you look overall in 2 large studies. The lower 2 reports looked at older patients. They also used propensity matching. And what they found is that if you did a segment, you did better than a wedge resection in one trial. And if you looked at patients that had long life expectancy versus short life expectancy, then in the short life expectancy patients, you started to see that radiation and surgery had similar results. So what about randomized trials? So there have been 3 attempts at randomized trials. The Roselle and STARS were looking at lobectomy patients or lobectomy candidates, and these both had very large target accruals, about 1,000 in each study, and they both closed after only minimal accrual, 22 in one and 36 in the other. I was involved in actually the PI for Z4099, and this was a study to look at the high-risk patients, I mean the segment and wedge patients, and we had a planned accrual of 420, but we closed after only 13 patients were enrolled. Again, disappointing. So what were the reasons that these randomized trials failed? Well, in the lobectomy patient studies, there was no equipoise amongst physicians. I mean, surgeons just didn't feel that we were ready to do this, and we had several major centers that were approached, and they refused participation. In the high-risk operable, we had several sites that actually agreed in doing this trial, and we had 60 sites that were credentialed. There were politics involved in getting this site going. But what we found was the biggest barrier to accrual was that patients were unwilling to be randomized between a surgical therapy and a non-surgical therapy. And it was very difficult to present this to a patient and flip a coin, and for the patient to find out whether they were going to get surgery or not. So currently, I think, our best available evidence comes from multi-center trials that have used one therapy or the other therapy. And in terms of high-risk patients, ACOSOG C4032 was a multi-center randomized trial. And in that trial, we actually looked at a segment versus segment with brachytherapy for high-risk operable patients. And RTOG0236 was a multi-center trial done in SBRT for what were called medically inoperable patients. And they may not have been truly medically inoperable in that study, which was an issue. But anyway, those are the best available data. These were all multi-center prospective trials. And so let's look at morbidity and mortality, comparing them. So I think the surgical trial helped to establish what the modern day outcomes should be with a segment or wedge in a high-risk patient. And what we found was a 30-day mortality of 1.4%, a 90-day mortality of 2.7%, 30-day adverse event rate, grade 3 or higher, of 27.9%, and 90-day grade 3 or higher adverse event rate of 33%. And we found that a DLCO of less than 46% was associated with increased grade 3 or higher adverse events when we looked at different factors that impacted that incidence of complications. Now, for SBRT, you would expect the complications to be less, but they still saw 23.6% grade 3 or higher adverse events. Their complications tend to happen over time because the effects of radiation tend to cause injury over time as well. They didn't have any deaths in this series. What about pulmonary function? You'd think that pulmonary function might be worse after surgery, and I'll show you that it actually might be better after surgery in these patients. So when we looked at pulmonary function, we defined a drop of 10% or more as being a significant drop, and we also looked at the median change over time. And what we found, and for the RTOG study, what they did was that they devised a toxicity scale, and they took a 0.9 to 0.75% and considered that to be a grade 1 toxicity. And essentially, that's 10% to 25% toxicity. And they looked at the mean percentage change over time. So this is the surgical series, and you can see that the median change was only +1 for FEV1 and -2 for DLCO. So essentially, PFTs remain stable over time. And then when we compare the two studies back to back, we'll see that in terms of FEV1, we only had 14.5% of patients who had a 10% decline compared to 38% of patients after radiation therapy. In terms of DLCO, it looked to be about the same between the two groups. And in terms of the mean and median change, there's actually a greater change with radiation rather than with surgery. So this kind of favors that surgery might do better because the effects of radiation occur over time, whereas with surgery, it's kind of an earlier issue. Now, more importantly, what about recurrence and survival between the two studies? And there have been some papers and presentations on this. So I mentioned before that the radiation and surgical definitions of recurrence are different. So in the surgical paper series, we said that local recurrence was any recurrence within the primary tumor lobe, either at the staple line or elsewhere in the lobe, and also within hilar lymph nodes. In the radiation study, they initially only used failure as being failure at the radiation site, and they didn't consider what happened elsewhere in the lobe, but they had to then go back after they submitted this manuscript and included the rest of the lobe. They did not include lymph nodes. So lymph nodes were actually counted as distant metastasis or regional metastasis. So if we look at the patterns of local recurrence in the surgical study, and just look more at the overall local recurrence rate was about 12.5% using the definition we defined. But if we take out lymph nodes, our local recurrence rate was about 9.4%. So this is recurrence within the lobe, but doesn't include the lymph nodes. Now, if you look at the radiation trial, and their local recurrence rate, when they did their longer follow-up, actually was 23.6%. So actually higher and much higher than what they normally quote. And then in terms of survival, at 4.38 years, overall 3-year survival was 71.4% after surgery. And if you look at survival in the radiation series, 3-year survival was 55%, and the median survival was 48 months. So again, it seems to be less. So if you put the two trials again back to back, you'll see it follow 4.38 years for the surgical series, 4 years for the radiation series. Local failure, if we don't include lymph nodes, and we're now using the same definitions of recurrence, it's 9.4% versus 23.6%. And then we look at 3-year survival, we do better with survival after surgery. And you can argue that there may be differences between the groups, but there was also another paper, which I didn't put in, where we looked at lung function, and in actual fact, the radiation patients had better lung function than the surgical patients, showing that there's an issue with how patients are selected for trials. So now this is a confounder. So this is the Chang analysis. This created a lot of hype when this was published. And what Chang did was that he took the data from the 2 randomized trials in good risk patients, and he pulled the data. So basically there were 58 patients, and when he pulled the data, the 3-year survival with radiation was 95%, and the 3-year survival with surgery was 79%. So the first conclusion was that patients live longer with radiation, and their recurrence rates were the same. And again, complications, as you'd imagine, would be higher with surgery at 44% versus 10%. And so this was kind of, I guess, the first missile salvo from the radiation oncologist. Now, the surgeons answered back, and there was a lot of, I think there were about 7 or 8 kind of responses with people unhappy with this paper. And, one of the problems, only 36 out of patients in one trial and 22 in another trial, so really very underpowered. And then if you look at the risk of mortality, the surgical mortality in the radiation trial was 4%. If you look at the STS database for VATS lobectomy, or for lobectomy, not VATS lobectomy, it's 1.4%. And if you look at a series of VATS lobectomy, it's 0.8%. And then again, if you look at our high-risk group, where we're not even looking at lobectomy patients, we're looking at patients who are at higher risk, it was 1.4%. So there's an issue with surgical quality. 80% of the resections in this series were by thoracotomy. And if you look at stage 1 lobectomies, in the United States, for stage 1, more than 50% of stage 1 lobectomies will be VATS, and 11% of patients who were supposed to have a lobectomy didn't even undergo a lobectomy. And we have no idea of lymph node evaluation, as they didn't provide any upstaging data, so we don't even know if they addressed their lymph nodes. Another thing was that in the Roselle trial, a tissue diagnosis wasn't needed. So 8 out of 11 patients in the Roselle trial had no tissue diagnosis. And so what this underscores is that we need a prospective trial, and we should probably be doing this in high-risk patients rather than lobectomy patients. And you'll still hear a lot of radiation oncologists saying that they already in their mind believe that radiation is as good as surgery for these high-risk patients, and we should be looking at it in lobectomy. So this leads to the Stablemates trial, which is the current trial that we have in the United States. And the idea of the Stablemates, and I'm a co-PI in this with the radiation oncologist, and my co-PI loves animals, and he thinks of the surgeon and the radiation oncologist as being racehorses in a stable. I kind of think of us as being the better racehorse, but never mind. But it's the so it's the Stablemates trial. And the difference here is that instead of randomizing the patient and then the patient finding out what they're going to have, is that we present the trial, we screen a patient, and if they're a good risk patient, they're eligible patient, we randomize the patient, and then we present the trial to the patient. And this is much more acceptable to patients. And to give you an example, years ago, mastectomy used to be the standard of care for breast cancer. And the NSABP tried to prove that lumpectomy was as good. So they tried to do a regular randomized trial, which was doing very, very poorly. So they used this approach. And this approach, they were able to complete the trial, and it changed medical history. And it changed medical practice in that lumpectomy with radiation is now the standard rather than mastectomy. So we're using this approach, and already we're about 10% accrued on our trial. And so this trial is moving, and we've got about 50 sites already that are participating in this. So I'll say that, in conclusion, that I think that the issue of radiation versus sublobar resection is really one of the most important questions that we face in the thoracic oncology community. I think that there's no doubt that SBRT is effective, but it's effective for the medically inoperable patients. It may be a good option for the high-risk patient, but we shouldn't just accept it, and we shouldn't just roll over, and we shouldn't put our heads in the sand and ignore this. And so prospective studies are needed, and I think we should all keep on saying that it shouldn't be done in lobectomy candidates, and the only patients who it should be done in who are lobectomy candidates are those patients who refuse to have surgery. And I think Stablemates is an important trial. It will help inform which patients might be better treated with SABR or sublobar resection, and it might prove that what I've said is wrong and SBRT is better, but we need to do a trial to prove that. And so I'll stop there. So thank you very much.
So questions?
So Chris, you had brought up breast cancer, and it kind of reminds me of transition from the whole steady into the Fisher-in concepts, and I'm wondering if it's going the same way, where they went from mastectomy to partial mastectomy and an axillary cleanout to basically wedge resection and sentinel node biopsy. And I'm wondering if it may go to sublobar resection, sample a node, and then a combination of course, the hormonal, you don't have hormonal aspects to it, but therapy like that.
Yeah, I mean, that's true. So the lung cancer study group, when they published their trial in 1995, that was really kind of answering the same question. A lot of people felt that a segment might be as good as a lobe. It turned out not to be the case in that particular trial. But now that we're dealing with smaller tumors that are being found, and there's a lot of data from several centers for these small peripheral tumors that a lesser resection is as good. It's led to these 2 big randomized trials that have recently completed. So I think the standard of care will likely change, and at least in terms of surgery, we'll find that the lesser resections for the small tumors will become more standard. Now, the question is, what about these non-operative therapies? So you have SBRT, which there's a lot of stuff going on, and then you have ablation, which is another thing, which would take away completely from surgery.
If you don't give it away, like
if we don't
cardiac guys did.
Right. So one thing, we have to be engaged, and we have to be doing these procedures or be involved in it, and we have to push to do these studies. And I'll see sometimes when I talk about to sites about trying to open the trial, I'll have surgeons saying, "But I'm not going to do that in my patients. The surgery is much better. You know, I'm not going to do that." But you have to. You know, you can't put your head in the sand and ignore it. If we do that, we're going to lose the battle.
There's another question.
Hi, Ricardo Santos from Brazil. Chris, we always think about the patient and the tumor size. Do you think in the future histologic type could be also put in this to see if like have like high-grade dysplasia for esophageal? Do you think have lesions in the lung that could be feasible for ablation therapies like SBRT or others, instead of think only about size and if the patient fit or not for surgery? You think this will be in the future discussed?
Yeah. No, I think that's going to come into it. So for some of the minimally invasive adenocarcinomas and the adenocarcinomas in situ, maybe ablation or SBRT may be a reasonable option. And I certainly think it's reasonable to treat high-risk patients without a tissue diagnosis, like with SBRT. I personally think that's reasonable, and treat them with SBRT. But what I don't think you can do is use that data to then say that that's better than surgery, because you don't know, you're treating some patients that might not have surgery. So for instance, in those single institution centers that compared SBRT and surgery, in the SBRT patients, about a third to a half of the patients had no tissue diagnosis, whereas in the surgical series, every single patient that was entered in surgery had undergone a wedge resection, and every single patient who was actually included had a proven diagnosis of cancer. And they didn't include all those diagnostic wedges that we do for patients that actually turn out not to be cancer.
Jens, may I?
Yes.
And it's very nice data, and you need to point it out that the patient with in high risk group of patients, VATS lobectomy and VATS segmentectomy is much more better tolerated than the open one. So this is another gap for to support surgical resection instead of severity.
Yeah, no, I agree with that, and I think.
And all this data is about open approach,
right?
Mixing together veg and segmentectomy,
right,
which actually is not the same procedures at all.
Right. You mean between a wedge and a segment?
Yeah.
Yeah, I agree with that. But I think then that there's a point, say, if you have like a 1 centimeter tumor that's peripheral, and a wedge with a wide margin may be as good as a segment. So an extended wedge with a margin,
except intralobar lymph node dissection, which is crucial for the long-term results.
Maybe crucial.
Potentially crucial.
Yeah, potentially crucial.
Okay, thank you.
Yeah.
But Krish, how do you proceed with a conference-based decision-making in an eligible candidate for a lobectomy or at least sublobar resection if the radiologist says, well, we can do it? In the conference, how do you go on then?
Well,
cases presented.
You're talking about the radiologist or the radiation oncologist?
Yes.
So I always push back if that comes up. I mean, and I say when they say, well, our local recurrence rate is as good as with surgery, I say no, it's not as good as surgery. It depends on the definition that you have, and I think you need to look at survival. I said the only way we should do this is in the context of a trial, but you'll see. The radiation oncologist will push back. The radiologist will often say, I can just ablate that. I can do the tissue biopsy and then I can ablate it. But the radiologists don't follow the patients. They don't think about lymph nodes, and they do the procedure and then they walk away. Yeah, you know.
Well, that is the debate is going on. I think we all, some of you may have been during one of the latest AATS meetings where there was the database based highly with a nice scientific background, this study of several thousand patients with a 5-year follow-up with a almost 15% difference if you look at histologically proven carcinomas, wedge versus SBRT, with the advantage even for the wedges. Do you remember?
Yeah, I think Nasser Al-Tulki's group was the one that led that, and the wedge seemed to do better than the SBRT, because but in as surgeons, if we do a wedge resection, we shouldn't just stop at the wedge. We have to go after lymph nodes, because if we take the assumption that the technology, the ablative technology, is as good as doing a wedge resection, if we stop at that, then they're going to be as good as we are, right? But and that technology is always improving and changing. I mean, they have protons coming down the road now, and sites are starting to develop proton centers. And then in the ablation field, we're getting microwave, cryoablation, RFA, nanoknife, which are all different ablative approaches. So we as surgeons still have to go after lymph nodes, whether you do a wedge, whether you do a segment, and taking Vladim's point of the segment may be better in terms of the intersegmental nodes. That's important as well, but we need to take lymph nodes as well, and we need to think about margins.
Thank you.
Thanks.
And now it's our pleasure to listen to Francis Ferdinand from New York, presenting on ISMIC's consensus conferences.
Thank you. So I'm going to talk a little bit about our consensus conferences. You see, our thoracic colleagues and folks who deal with cancer do a really great job. And I think more in cardiac, we should almost think about, when we look at disease states, if we look at the oncologic approach as far as stratifying data and survival, I think it would clarify a lot of issues. And also the concept of a tumor board meeting where everybody, discusses the therapy of the patient. Now that's kind of come back for the heart team, which most people think is related to structural heart, but actually started in Europe with the revascularization guidelines, whereas a patient would get a diagnostic cath and then they would meet with the non-interventional cardiologist, the interventional cardiologist, and the surgeon to discuss the best therapy for that particular patient. Now, we do ISMICs, as Dr. Chung had mentioned, about every year we've done a consensus conference, and we do this at great cost to the society because we believe it's incredibly important to look at what we do. We all like new technology, new techniques, but are they any better for the patient? Does it help them? And the only way to really do that is to rigorously analyze the data that's available and then determine if that's an acceptable treatment, or is it an advancement, a true advancement in the field. One of the challenges in surgery in general is that there may or may not be a device, and therefore oftentimes most clinical trials are based on a company selling a device. And so some of the things that we've run into is that there may be a lack of long-term studies. Now, ISMICS doesn't publish a ton of consensus conferences, not like the American Heart, American College of Cardiology. However, our consensus conferences are incredibly high quality. And this is a chart that we did, and you can see on the left side the consensus documents from ACC and AHA. The vast majority of those were of rather low quality. And this was an update we did in 2010. The original consensus conference that ISMICS did was in about 2000, and it looked at OPCAB, and then we revisited that in 2010. And you can see on the right side, the ISMICS consensus statements, the vast majority of them are based on level A or B evidence, and level A is, prospective randomized trial, whereas C evidence that most of the ACC is essentially opinion. So we do fewer trial consensus conferences and meta-analyses, but a much higher quality. Now, we updated that so that this is the most recent one, and this again was published in JACC, the paper on the left, and you can see the number, and I put at the bottom a little summary, that in the ensuing years, Again, the ACC and AHA, the vast majority of them are still based on opinion, low quality evidence, whereas our ISMIC statements, this is how many we've done, looked at over 1 million patients in the various consensus conferences, and you can see they're the high quality level A or level B. The vast majority of our statements are based upon very good high quality evidence that's been rigorously analyzed. So this was the OPCAB paper I mentioned that was updated. And again, this was a challenge. All of the morbidities associated with CABG procedure were better with OPCAB. So pulmonary dysfunction, bleeding, neurologic, renal. The only questions we had or difficulty were the fact of survival, long-term survival, because there were very few studies that looked at survival that had more than a year of follow-up. And this is where registries, although not a prospective randomized trial, but using the Society of Thoracic Surgeons database, looking at large number, thousands of patients from registry data or from large institutional data, when they did things like a propensity analysis to kind of mimic the effects of a prospective randomized trial, those are the only data that are actually out there that looked at long-term outcomes for OPCAB, and it was clearly showed to be improved with OPCAB versus standard CABG. And so especially the sicker the patient, kind of like what the Syntax trial showed, the sicker the patient, the more arteriosclerotic burden, the better they did with the less invasive procedure, such as OPCAB. So what we decided to do was we had first published in 2005 at ISMIC's consensus conference on endoscopic saphenous vein harvesting. And there were some numerous trials that came out afterwards, and I'll discuss those briefly. So what we thought we would do is we would re-look at that. There had been some updated information, not only in saphenous vein, but now there was studies available on radial artery. So this consensus statement looked not only re-looking at saphenous vein, but also added radial artery to this. And this was our steering group. And it's a very international group, and you can see, myself and Bob Kai, John McDonald's actually a new statistician that ISMICS is using, so this was our trial with him. And we had good representation from Europe, from North America, from Asia on our panel members, and you can see once all of the data crunching was done ahead of time, we all met in London, which was quite nice. And we're basically locked in a room until we hash out the differences and then come up with some statements based upon the data. And so these were our objectives, to look and to see if endoscopic saphenous vein or radial artery were better in terms of wound infection and postoperative reintervention. Obviously, cardiac events were important to know. And so these are the types of questions we wanted to answer by looking at it. And so the methods were to really go through and just look at every possible, and this is all done through electronic means and then looking at the preliminary data, but we looked into large databases to pull out data on that. And then to look at both randomized and non-randomized controlled trials, and to basically go through a step-by-step logical fashion and pull every citation out that mentioned any of the key terms and look at it. And ultimately, what we also used is we used these grades of evidence. This is an updated version by Halpern, and we looked at, how do we define level, class of recommendation that we're going to use on the left side and the levels of evidence to make the proper statements. And the updated one breaks out the randomized versus non-randomized trials. And so we used the latest, this was I think 2016, this was an updated published, to look at how we evaluate the data. This is a flow chart, and you can see how many studies we started with. We had some from our 2005 trial, and then weeding them down progressively as we go down here towards the bottom of how many studies are applicable, how many have complete data, how many had defined questions, until ultimately we have a pool of studies that we can look at that can be evaluated. And you can see here the top bar is the original 2005 consensus statements that we did. In blue here are the new ones that have been published since 2005, and at the bottom is the total number of studies that were evaluated. This is typical. I won't show you a lot of these. They're very difficult to read, but the Fisher plots, where if we look at, for example, wound complications for saphenous vein graft, we look at all the studies. Up top are the non-randomized, and below that were the randomized trials, and then we look at the effect across the center line of whether there's a benefit towards endoscopic vein or versus open vein harvesting. And the same thing for radial artery here. There's clearly much less studies. And you can see the benefit for wound complications clearly to the left of the center line there, and it has a significant benefit of doing it endoscopically is related to wound complications. We'll go through everything. But every question that we looked at, whether it was cardiac events or reintervention, there was a set of Fisher plots where we analyzed all the data and looked at it that way. And so the first question was, we looked exactly at that, about the complications related to it. And then these are the statements, and I won't read all of them, but you can see is it significantly better? And then at the end of the individual statement, we put what evidence that was based on. This is based on level A evidence. So this is the highest quality prospective randomized trials. And then based upon our individual statements for each one related to the wound complications, we can then look and make a conclusion that we recommend EVH, and that's our class of recommendation. Obviously, 1 is the strongest, and level A based on the highest level of evidence. So, for example, for the question of wound complications, is endoscopic vein superior to open? And it clearly is. And then we broke it down into various other questions that we wanted to look at. What the statements were. Some of the evidence is not quite as strong. It could be level B based on randomized or non-randomized trials, and what our consensus statement is recommended on that. And sometimes it was non-inferior, which is actually a good thing because it's equal to open. So it didn't have to be superior. Wound infection or wound complications, you could imagine, versus a big incision in a leg that has to be sutured up versus 2 tiny endoscopic port sites, basically, it can have a significant advantage to that. And again, we went through all of the questions, looking at these and a series of statements related to that and our recommendation. And so this is, oh, sorry about that. This is backwards. So the other statement here, and ultimately our recommendation. So ultimately, after breaking down the number of questions and looking at the data and making statements, then our conclusions are that, that we recommended it, and what our, this is class 1 level A, and all the way down for wound complications, for reintervention, mortality, functional mobility, and ultimately breaking all of these down, this is how we can recommend that we use endoscopic saphenous vein harvesting and why we think this is better. And then our consensus summary was that we believe that this should be the standard of care. Now, clearly, and anytime you evaluate all of this extensive data to look at this and look at the current situation, there are room for improvement in various areas. So future directions here, you can see that, there's a need for more studies. There's a need for further looking at issues, especially things like resource utilization. Dr. Benetti's in the room here. So when OPCAB was first started, part of the reason that people thought of using OPCAB was the cardiopulmonary bypass circuit was expensive. And it was cheaper to do it with OPCAB. And that's at different health systems in different countries, someone has to pay for health care in one way or another. And so looking at cost effectiveness is important, and that's always a tricky thing to do. So these are some shortcomings that there may not be extensive data. We had less to work with, but they're very important to do. So we look at something that not only benefits patient, but it may be cost effective. And cost effective could be meaning the equipment costs more or less, the time it looks, or even the patient is able to return to a functional lifestyle and return to work and society quicker. There's a benefit to that that's an economic benefit in addition to how well the patient's doing. And those are important questions to ask. In a similar fashion, we looked at radial artery. And again, for complications as far as wound infection and mobility of the arm and functional status and reinterventions. And again, I won't bore you by reading all of these, but you can see that as we go through each question, we look at the various studies. excuse me. And we make a series of statements and then ultimately our recommendation for why we think it is important. And again, like I said, so for reintervention, so wound infection, reintervention, functional mobility, quality, all of them, and then come up with our summary statements and ultimately our conclusions that we think that this is important. And again, similar for radial artery, which has been used less, not as quite as much as with radial arteries in general aren't used as much for bypass, and so clearly endoscopic harvesting. Some people think that the radial artery, there's rarely get a wound infection in the forearm, but even with that, like I said, you can see from the data that there is a benefit as far as wound infections, even for a radial artery in a forearm, which is relatively well vascularized and well perfused and usually doesn't have wound infection, but even in that situation. And another important thing with the radial artery being more prone to spasm, there was a lot of concern initially that when you're manipulating the radial artery with the endoscope, you could cause worse problems. And so it was reassuring, especially with the radial artery, to see that there was no increase in reintervention in the radial arteries that were harvested endoscopically. So it had some clear benefit. But again, the more studies that can be done to look at and fine-tune some of this, the better. So this was our group, and you can see that's after we were, let out of the room after a couple days. It was getting a little ripe in there, and after we looked at everything. So now this, after after this conference, we then set about, this was presented last year at the ISMIX meeting in Montreal. The similar recommendations, we fine-tuned it since then, and pleased to know, for the organizational point of view, that this has now been submitted to the journal Innovations. It's been accepted, and I think it's going to be in the September-October issue of Innovation, so it'll be something to look at. And at that point, I'll finish there. I want to thank you. If you have any questions, I'll be happy to answer them, especially if this is from my college entrance exam there. You can see I was able to identify that complex mathematical answer. And if you have any similar easy questions, I'd be happy to answer them.
So, I was going to ask, so you said future direction and looking at things like cost and things like that, but or crossover trial, but the data is so compelling in the sense that you have the level A evidence that shows that wound complications are less and everything else is non-inferior. To me, it seems that you'll never be able to do a randomized trial again to look at that question. So I don't know how you'll answer those other questions without a randomized trial.
It's challenging, and that was the level of evidence for the quality of life. There are only two major studies that actually looked at the, we're able to get the finance, hospital finances are pretty, they can almost, the hospital can say almost anything they want. So it's tricky to get that data. And actually some of the, in Canada and some of the nationalized health systems, when they have one way of billing, it's sometimes easier to get financial data. Now, it may not be applicable to other places, but that's certainly a challenge to get that where they looked at that. I mean, clearly, if you just look at wound complications and post-operatively the patient's discharged home, they don't have to get readmitted or they don't have to have multiple office visits to, to look at the wound or take care of it. That's got to be, cheaper, but actually quantifying how many dollars per quality adjusted life year and things like that is important. It's very well established in North America. It's more so in Europe and other countries. Latin America, other parts of Eastern Europe, it may not be as well adapted because the cost of the device. In the US, I think it's around $900 just for the device to harvest the conduit. And some use two, actually. If you're doing a vein and a radial, in some places reuse the same one, they'll take the vein and do the radial just for the cost of the device. And so to justify that additional cost, you have to show, well, what's the, where are you saving the money? You're spending more money up front on the device. Now, where are you going to save it afterwards?
So in bariatric surgery, they have kind of like gold star centers and then the intermediate centers, and they base it on certain quality outcomes. Do you think, or do you foresee that if you don't offer endoscopic saphenous vein graft, that that the insurance companies may take that, and people may say that you're not offering gold standard service, and that there'll be a rating system around the
Potentially it could, although, again, in North America, it's so widely adopted that just for patient preference and the physician preference, it's so well adopted that it'd be hard to find a place that doesn't do it. Just because the morbidity of a long leg incision with patients who are sicker today have diabetes and peripheral vascular disease, so the wound complications are much greater. So it's so well adopted that it'd be hard to say that. But the STS hasn't put it in a composite score. That's the most broadly defined thing that, say, Blue Cross Blue Shield does in their centers of distinction. So endoscopic vein isn't in that, but it's well adopted. People saw the benefit of it so greatly just in the number of visits. I mean, I remember before this, virtually every office or clinic session that you would have for your post-surgery patients, there'd be 1 or 2 patients you were packing the wound, or they ultimately healed up, but there was an extra 3, 4, 5 visits just for local wound care, and now that's disappeared.
Another question?
Yeah. Congratulations, very interesting. The problem is the cost. I think we need to look at other options, because bridging technique is an option, and the other problem is long term. We don't know what happened with these veins.
What happened?
We don't know exactly what happened with this vein that you take endoscopically.
Well, we actually looked at, you recall from that statement, they looked at endothelial
10
damage
years.
scores, and they looked at reintervention. There were some that had angiographic follow-up, and it was not. So the 2 areas of controversy that we wanted to look at, too, there was a Ruby trial,
Correct.
which was a VA, and it created a lot of press because it's prospective randomized, but it was randomized to how they did the bypass surgery, not how they harvested the vein. So it was a post hoc analysis, and that was refuted. And then there was the Prevent 4 trial, which was putting an EF2 decoy. It was supposed to prevent proliferation in vein grafts. That study, when it ended, didn't show a benefit to using that treatment of the vein grafts.
Correct.
But again, they had done a post hoc analysis on that data, claiming that vein graft was worse. But subsequent studies and careful analysis of that data show that that was not the case. So that there is really no negative effect of vein graft harvesting with endoscopic technique versus open. But there's a learning curve.
Yeah, absolutely. And the other, that we need to develop new technology to take the vein with the tissue, because
it's complicated, and that's one of the things that we wanted to look at if we do future studies, is what's the training of the individual harvesting it? Is it a closed system versus open system? So there's some finer nuances that if they could get the studies done.
Congratulations. Very nice work. Thank you.
That was great. There's one other question, excuse me.
Is technicians or residents?
No,
Because,
so
we have published our data for 3-4 years ago from Denmark, from Aalborg, about harvesting endoscopic, and it was very exciting, very nice and good. But the problem is that experienced surgeon, they want to operate on heart, not on vein. And residents, then when they are good at it, they move along to the other department, and we have a problem for experience, for routine in this harvesting. That's the problem.
That's a great question, and it's an important one. In the U.S. and in Canada as well, I believe, residents have been essentially, they're not involved. And I can't do this. So we have physician's assistants, and they get trained up, and there's consistency, and they're the ones who harvest it. Now, in Europe, I understand, I apologize, I forget the term they use. They don't call them physician's assistants. There's another term they use. But when I worked in London, over 10 years ago, when I worked at the Royal Brompton, having a physician assistant-like person was a new concept. And now it's much more regular and established. And those are the ones who are harvesting it, because you're right, residents come and go. They might only be on, and in the U.S. now, with the whole change in the training system,
general surgery residents are no longer required to even have cardiac experience. So we rarely see general surgery residents anymore, and which is a shame, because when I was a resident, the surgeons could be up at the top screaming at each other, but in the resident, you know, if you're nice to the nurse, they gave you a bunch of packs of suture, and you had a good, you know, 45 minutes to just sew. So you really spent, you know, I don't want to say anything about the simulation. They had a talk yesterday. You didn't need to go to simulation lab, because, you know, every day you were in there sewing for 45 minutes to an hour. You got great experience. But I think the consistency is important, but it requires training.
Thank you very much,
Thank
Francis. So just to let folks know that the next consensus conference, we're actually going to be looking at minimally invasive approaches for lung cancer, which hopefully will answer some interesting questions, or maybe have questions that will need to be answered. And the next talk, I'd like to introduce my co-moderator, Dr. Jens Ruckert, who flew in from Berlin this morning. And so he's going to discuss minimally invasive resection of large anterior mediastinal tumors, and should this be done. And Jens is probably the biggest experience of robotic resections for thymic lesions, so it'll be interesting to get his perspectives.
Well, this time, ladies and gentlemen, I tried to include not only the technical aspects, but some background, some basic questions that were known before, but will have some significance for the future in that field. Of course, we could state, should it be done? Okay, this question has to be answered. Was it done, or was it done from the beginning? With some centers, yes, as always, with all the surgical techniques, all the surgical fields. In the beginning, there are the beginners that were always convinced, and this is an interfering project here. I remind you that one of the highest ranked surgical prospective randomized trials was published in, I think exactly 1 year back, in August 2016, on the question, should we at all operate for myasthenia gravis? And we all know that has been a question over decades, with some of the most exciting debates worldwide, transcervical versus sternotomy approach, and so on and so on. But no one really knew officially if there would be a chance for the operation, or a sensible approach with the operation. Nevertheless, if now the answer came clear that this is an essential part of the comprehensive treatment, and it is proven on a level 1A, so then we should go back to the data we had. And this is something we tend to forget about. Then the basic idea to question again and again, and to question the operation for myasthenia gravis, was a very weak database, constructed, a little bit constructed by our neurological colleagues, because they only were convinced that studies from the past who compared operation versus non-operation had a chance to be basically valuable to get the answer. All the ongoing consecutive surgical series with much better results that would never ask for a study were excluded before. Now we have to go back, and this is the same with the tumors, I think. Look, here, I included three basic questions with actual literature. The first one is, all our concentration in the field of anterior mediastinal tumors has always been, there has to be a radical operation, a radical thymectomy. Therefore, the necessity for sternotomy was much more felt for tumors. That was quite clear. That was a no-go area to have minimally invasive operation at all, when minimally invasive thymectomy was well established. For thymomas, very much later, the question came again. And I know colleagues from Europe, very skilled colleagues. I mentioned Italy. I can mention personally Federico Ria. We all know him, I think. He told us over several years that because of medico-political reasons, he was not allowed. He could not dare to touch mediastinal tumor with no sternotomy, with below sternotomy, with minimally invasive approach. Then look at this. Here we have only one, but a multi-institutional propensity matched, but that means a better, higher scientific level study, even telling us that you only have to excise the thymoma. The ITMIC, or the ITMIC roots, International Thymic Malignancy Interest Group, would be very excited and nervous because this is not the standard. And you see, if before the propensity matching, there is with overall survival and recurrence, no difference. And if you match, then overall survival is better for complete versus non-complete thymectomy. So here we have some data that would mean if we would say, okay, local excision is right, is a way to go, then all the discussions, also the question of today is away. There is no more question, because then you might be allowed from the beginning to do anything to excise. The most difficult thing is the completeness of the resection. And here you see that sometimes it's not so easy. Next, the second question, background question is, here, propensity score matching and comparison, robotic versus transsternal thymectomy. And again, you see, if we just have not really the time, but you can see here, oh, that works a little bit. You can see that this comparison here, where we have the matched and the non-matched and the matched robotic versus sternotomy data, you can see that there is a slight difference, and there is almost 5 centimeter diameter that are, yes, a little bit the larger tumors. That is our topic today. And there has been an advantage, as you can see here, as to the morbidity and hospital stay and length of stay data. There have been advantages shown for the robotic approach versus the sternotomy approach. You can see here, unmatched, but even matched data, there has been a difference. And this is a center, by the way, that operated on really highly specialist South Korean center. They have a society for dealing with the anterior mediastinal masses and operate at a frequency of, I think, 200 patients in 15 years, 200 tumors of one center. This is a lot. So, and here you can see, again, this better clinical outcome with no inferior results as to the survival data, which always is interesting. And this is, and excuse me, this is not, has been not overall survival, but maybe even stronger question, the recurrence, and you know you have to wait for at least 8 years. That has not been completely fulfilled in that study, but I think the results point to some value in robotic approach here. And well, next. The third question is another important question. With the new TNM classification, which some of our colleagues always wanted to have some unification process, therefore even for thymomas there should be a TNM, not only Masaoka Koga and WHO, that was not sufficient, felt not to be sufficient, another TNM. TNM means you include as you may know from beginning of last year, all the thymomas are classified now as malignant. There are no benign classifications anymore. And the second is that important question with the superficial and the deep compartment of the lymph nodes, N1 and N2 for thymoma. And of course, it should be a difficult thing to do all the minimally invasive approaches and to harvest N2 lymph nodes with thymoma, which no one did in the past. And if now that should be done in all the cases, then should be another interfering question with minimally invasive approaches. That's quite clear. Are there patients at higher risk? I think we find from that study here, we find there are patients clearly at higher risk for lymph node involvement. This group isolated of a background of, I think, more than 200 patients. They found, no, it was 500 patients with thymomas. They isolated 131 patients where they, for different reasons, had an extensive lymph node dissection. And this lymph node dissection was further analyzed. And as you can see clearly, first thing is that former WHOC, that means thymic carcinoma, which is a little bit apart from thymoma, is the one interfering with the lymph nodes. There you have the lymph node involvement. And the second thing is that higher stages of the new T, that means T2 tumors, T2 and T3 tumors, translating into Masaoka 3 and higher sizes. And this is our topic today. Also the size above 6 centimeters. These are the risky tumors for lymph node involvement, but altogether at a very low percentage. Again, don't forget about this among us as the specialists. There is a big difference between these topics of the lymph nodes with lung cancer or with mediastinal tumors. And you can see here again that this difference I mentioned, it's about 6 centimeters of size. It's about the WHO higher risk B2, B3 tumors, and of course the type C. And as you can, well, this is again to mention here, this is the T2, T3, where there is the difference. And in general, all the others in the in the analysis that included all the factors, these 3 points were of importance. Of course, if you have a lymph node involvement, then survival and recurrence is almost guaranteed, or these are high-risk patients then. But you have to focus on who are the candidates for lymph node dissection. This is in the background very important if we discuss the minimally invasive approaches for thymomas. Greetings from Berlin, our new building in Berlin. But we were dealing over a time with these patients. At the beginning of this year, we can include in our series 100 out of 600 robotic thymectomies, 100 thymoma patients. And you see the average size is 45 millimeters. That is our background. 70% of these patients had myasthenia patients because we have a big center of myasthenia gravis. And Well, what about the approach now? Oh, turn back. The first thing is about decision making. And if you have such a patient, 73 years old, that means over the average of thymoma patients, and with a suspicious diagnosis of an upside down stomach, which you can't see here, but the diaphragm was up at the left side. Then the analysis goes to that tumor. You summarize and you find this should be a candidate with no thymoma, but a thymic carcinoma, which turned out to be true with infiltration, heavy infiltration here. This is not the eligible candidate for minimally invasive surgery from the beginning. But the point is decision making in advance. And there are guidelines, meanwhile, to very extensively study the CAT scan anatomy with 12 different parameters, only from the radiology background to be analyzed before decision making for minimally invasive approaches. Then are children, maybe with myasthenia gravis, as in such case, are children not the candidates for suspicious tumors? By principle, yes, but as an exception, tumors may be found, as in this case, only intraoperative diagnosis of a tumor, then extensive resection, but with a minimal invasive approach, and radiotherapy afterwards. Again, 75 years old patient with a suspicious of myocardial infarction or a pulmonary embolism, turned out to be, unfortunately, not the case, but a huge tumor, as you can see, was found and analyzed. This is the case to remind all of us, this is a case for preoperative biopsy. Otherwise, we would not insist on a biopsy, but here, yes. And a difficult, very rare, very seldom case of a thymic carcinoma. Is that always an exclusion for a minimally invasive approach? Here, all the radiologists in the tumor conference told, well, there would be infiltration, maybe more to be found, but the point is here, exploration with a minimal invasive approach may help and should be recommended. And in the end, we ended up with a pure minimally invasive operation. At the end, you see 3 incisions. This one a little bit, here the tumor was taken out, a little bit extended incision, 1, 2, 3, and 75 millimeters thymic clear cell carcinoma. The patient is doing well. I don't know if that works or not, or who can do it. I can't do it here. And it's, I think, otherwise we switch. That should explain that it's can be made very safely to, yes, thank you, to place the trocars. Because there have been discussions also in the US that there would have been even fatal instances with a trocar placement. We do that under visual control and in a non-robotic fashion, and if that is okay, then we don't waste money. If operability is given, then the robotic device is installed and the operation begun. Please, next, could you start it again? With a trocar placement, and you see under visual control, and if there is a little bit sticky area, then we insufflate CO2. You all know that this should be done to push away the mediastinal area, and in every case it can be done with a even with the help of CO2. And by the way, here you see that the thymic tissue is not only around, but above the margin of the phrenic nerve. And this is a 6 minutes video of a complete right-sided approach. We switch, and I only come to the last examples that should remind and stimulate you not to exclude these patients. Better to be seen here. There might be a small margin, and there was no infiltration, as in the case before, absolutely no infiltration, but a huge tumor, 11 centimeters here, had undergone in another hospital a biopsy. I don't know why, but they wanted to exclude a lymphoma, which they did. It was a thymoma, that's clear. Afterwards, we had to resolve adhesions, therefore included an atypical lung resection, but the mobilization and the visualization, here you see the additional, not to interfere here with the adhesion, but as you can see here, lifting up the whole tumor gives a very nice view at the phrenic nerve, and I have some doubt if that could have been done in these cases in the same manner at the left side via a sternotomy. That is much better with the visualization with the robotic device. Even 355 grams of specimen en bloc resection can be taken out like this, and the tumor was really huge, but as might be anticipated, there's a so-called rule, it's not a rule, but a suspicion that sometimes the larger tumors are the better ones, maybe the better candidates, therefore for minimally invasive operation. As you could see here, this was Masaoka Koga 1 WHOAB, so the size is not the only criterion. Again, a good solution for that patient, which was away out of the hospital 2 days later. And now the advantage is multifold, because these patients, like the gentleman here who had a complicated rectal cancer surgery, difficult post-operative, long-lasting course, and then this maybe metastasis, maybe broader differential diagnosis was found. In the end, it turned out to be another thymoma, and again, a good candidate for minimally invasive approach, especially because of the clinical background was a little bit more extensive in that patient. We could have a video impression how to much better. You could start that again. The tumors, and sometimes I can tell you again to the question from the beginning. With these tumors, maybe it's better to do a thymectomy than a thymomectomy with, let's say, a non-radical operation. That is another discussion, not only known to me, but to others too. And of course, we include, meanwhile, the excision of some part of the pericardium. If there is an adherence, that should not be an exclusion criterion anymore for a minimally invasive approach. On the contrary, as well as lung infiltration. And of course, you know, the cardiac surgeons know one of the first operations of minimally invasive of thoracoscopy from the beginning of the 90s was pericardial window. So again, we may excise or extract the specimen with one cut of one of the ribs, like here. Then we have an extensive en bloc resection, as you see. And I remind you again, what we tend to mention only size or sometimes larger tumors, like in the title of this presentation. But meanwhile, I know perfectly that the complicated tumors are not the large, as I mentioned, but sometimes if you have not a smooth surface like this, then you anticipate more difficulties. And again, a video of this 39 years old patient with a severe myasthenia. And if you get that started, then we see that the phrenic nerve, which you see then here, is not the border of the tumor. There is some. Can you try again? Should be possible to start. Yes. You see that also here is tumor. That is tumor. Here is the phrenic nerve. And even if you would think now, is that radical to excise here, to deliberate completely the phrenic bundle? Well, as you know, with a robotic device, Peter knows, Vadim knows, and all the others, it's you are really better convinced what you do and where you have to go, where you should not go with the dissection, with the third dimension of your intraoperative view. That's quite clear. The pathological workup was in favor of a radical thymectomy, and this patient, by the way, is in complete remission. What we do here is only take scissors, not to employ any electric device at the nerve. Okay. And a few tips and tricks at the end. Start with a thoracoscope simply, maybe helpful. Then use CO2 maybe from the beginning. And at what, sometimes we start with onto 25 millimeters Hg if necessary for a heavyweight patient, in accordance with the statement of the anesthesiologist, of course. Late opening of the contralateral pleural cavity is our statement, because not to lose the CO2 effect of enlargement of the operation field. En bloc resection, don't push the tumor with the tip of the instrument and never hold the tumor with an instrument. That's quite clear. Put some gauze between instrument and tumor. Use the endo wristing with both hands, and maybe with switching the instruments, and maybe as an exception to take another wave for extraction of the tumor that might be subxiphoid, in additional incision there. Clear the ipsilateral phrenic nerve, dissect from medial to lateral, and of course include what has to be included for a complete resection. Thank you very much for the extra time.
So we don't have another speaker, so we have a little bit of time for questions. Dr. Bernardi couldn't be here, so any questions from the audience? Ricardo?
Great talking, as always. Jens, what's the situation that you perform preoperative transthoracic needle biopsy, and what's the technique that you indicate for that? What's the special situation? I know many times you just go straight, but when is important?
We stick to the. From my opinion, it's a good explanation what was written in the NCCI guidelines, and that goes like this. First question: you have an anterior mediastinal lesion, which might be a tumor. You analyze completely all clinical data you have, the age, the gender of the patient, some clinical symptoms, the symptoms from the past, all the laboratory findings, then radiological findings, everything. If you answer the question, could that be a thymoma? Then you go to question 2. Question 2 is that primarily resectable? If the answer is yes, then you don't do a biopsy. With that policy, we admit we have around 10% of our anterior mediastinal tumor resections that are no thymoma, or turn out to be in the end no thymoma, but in none of the cases with some bad event or result, some inferior clinical result for the patient, because in most of the cases that is perfect, sometimes very surprising differential diagnosis, which would have taken much more time and money. If you can do a complete resection, you do a complete diagnostic too. There are examples we could analyze now. If the answer to the second question is no primary resection can be guaranteed, this is the case for a biopsy. And then maybe for a neoadjuvant chemotherapy, and there are some projects with thymoma, as you know, Ricardo, for even combined neoadjuvant chemoradiotherapy for certain kinds of thymomas. Maybe some study protocols for the future. This is our policy.
So I'll give you a case that I did like 3 weeks ago, and I wanted your opinion. There was a patient who was 69 years old, had a tumor on his left kidney, okay? And at the same time, during the workup, they found a mediastinal lesion. They're like, oh, this is metastasis, probably not. I've never seen anterior mediastinal metastasis from a kidney tumor. But then we did a robotic dissection. At the same operation, they went and they did a left nephrectomy, okay? During the operation, I took out the lesion and I gave it to the pathology. He said, oh, that could be a thymoma, that could be another lymphatic lesion that we don't know. They didn't give me like a straight answer. But I thought that was really well done operation and say, okay, margins are free. They had a nephrectomy to be done in the same procedure, so I stopped it. So the answer is there was a thymoma, a B1. They say this a T1A NX because I didn't go towards the lymph nodes. And now the patient is well. Should I go back to do anything else? Because I didn't do a radical thymectomy. What's your opinion on this case?
So you did a thymomectomy.
A thymomectomy, but like, free margins.
Like the first example of the multi-center study, there are more material on that, and I had to analyze this question, by the way, in 2011 for the ITMIC Congress. What about non-radical thymectomy for thymoma? Ricardo, I think, what about, may I ask about the size of the tumor? 4.2.
4.2. And it had a malignant lesion on the kidney that was also removed.
Yes. Do nothing is the answer. You did much more, as some centers would do. Some centers would answer, if you have a needle biopsy, if you would have done a needle biopsy before because of the kidney cancer to be treated, only biopsy, and you would have found a B1 thymoma. Some centers would stop at this and say, watch and wait. So you did much more, and for my opinion, the right thing. And maybe these patients, that this is in the future a way to go because of these data I showed in the first slide. Maybe this is a part of the strategy for such cases, not to be forced to decide about complete thymectomy or an excision only for very specified, special selected patients. So you did right, is my answer.
Another question. There's a, okay. Well, you may as well take the mic now. You take the mic. One by one. Okay.
Vitas from Denmark. I want to ask you, or a little bit change the point of view on those things. Thank you for beautiful presentations as always, and it's exciting, perfect surgery, of course. In Denmark, we have mixed departments, 4 departments, cardiothoracic departments, where we do all those things also, both VATS, open, and one center is now robotic, training other 2 centers robotic. But we always have the discussion about the post-operative pain because of intercostal nerve damage. And now one of our residents, he is writing the PhD on it, and the primary data is coming out that disregarding VATS or open thoracic surgery, you have late postoperative nerve damage with chronic pain in 8% of all cases, no matter VATS or open. And that is the point that now in Denmark, because it's all regulated from Ministry of Health and from our society, that it's consensus that if it's more than 5 centimeters, then it should be done open through the sternotomy. And one of the reasons, because the Cardiothoracic Association of Denmark says that when you have to spread intercostal space so much that you have to take it out 5 centimeters, you may have the higher percentage of handicapped or disabled patient who cannot come back to the work because of chronic intercostal pain. And from this point of view, what do you think the future of managing the big tumors through a little thoracotomy? Because sternotomy, as it shows, it gives less thoracic pain, chronic thoracic pain, than intercostal damage. Thank you.
Well, of course, a very important question, and a question that goes back to the 20 years back when thoracoscopy itself was meant to be the end of any discussion about pain in thoracic surgery, and the contrary was true, because we know the chronic pain, even if you don't spread the ribs, but if you have certain manipulations, some pressure with the instruments, with the stiff trocars, and so what helps, the figure of 8% is, well, it's a point to discuss about some measures to do, some guidelines to take from that. I can understand. On the other hand, you may admit, if you are working in that field, that you sometimes think this patient will be a little bit in trouble with pain, and he takes no painkillers. So you can't anticipate realistically who will have pain and who will not have pain. And as always, experience with these tumors helps. In the beginning, we thought that always the size, at a size limit of 3 centimeters, some centers had 4 centimeters, some had 2 centimeters, you would not be able to take the specimen out. And you know, it depends, for instance, to mention only one parameter, of the consistency of the tumor. And sometimes you can do it minimally invasively with absolutely no extension of the incision if there is let's say, weaker consistency. I don't know. Yeah. Yes. And if that is very, we do it like this. If that is a very firm consistency, these are the candidates maybe, and this would be a way out and a way to be discussed. Then to have a 4 centimeters subxiphoid incision as an additional part and to take the specimen out. You know about this movement to operate at all with a subxiphoid modification of the approach. I mentioned Marcin Zielinski, who does that at the moment, and many others too, the Chinese colleagues, the Korean colleagues. So I would really ask you to hesitate a little bit with guidelines asking for or defining the size of 5 centimeters to be candidates for a thoracotomy, any kind of thoracotomy. I would say certainly not. For reasons like that, and I would ask you, of course, personally, to be part of that discussion a little bit more, not only multi-institutional but multinational.
And I'd say, as well as the subxiphoid, you know, you make your robotic incisions; they're all small incisions. You can then make an access incision anteriorly and low down near the diaphragm, much in the same way as Dulesky does for his lobectomies. And the spaces open up a lot more. There's more costal cartilage, and it's basically, it's not as much pressure on the ribs and the intercostal nerves. So I think you have the ability to make an access incision in a place that will have less pain, or just make a subxiphoid incision and pull it out as a subxiphoid.
Practically, we do that. It's not time enough, but I can show the examples. How to decide intraoperatively, because you don't know before. And then if you find that you may think about one incision in the end, no problem. And the patient will have no or very low pain. But again, the question you put is absolutely correct and needs to be discussed by everyone, because there's no reason for hiding away these problems the patients will have if you don't act very in the best manner.
Thank you very much. Now I have some arguments, because we argue always with, you know, the oldest goldies with golden standards, sternotomy, big incisions, and that's why the progress should go. But we have to catch very, very good reasons and very good arguments. Thank you very much.
So one last question.
Let me ask you a last quick question. Come back to the definition. You present a topic about the large anterior mediastinal tumor. What does it mean large for you? For me, cut line is 8 centimeters. We do a job about it, you know, and we found that there is a differences if you operate by VATS, the patients with thymomas more than 8 centimeters, it makes differences in terms of oncological and perioperative results. If you operate the patients with tumor less than 8 centimeters, there is no statistically significant differences. What is the big or large tumor for you?
Well, Vadim, I think you rely on the Cameron Wright data from Boston,
and
of that retrospective study that found with all the MGH data looking 40 years back, and they found 8 centimeters size cutoff and 8 years, it's coincidentally 8 years follow-up time. That is the cutoff for higher recurrences. Therefore, yes, 8 centimeters is large, but the field of discussion is the examples I cited here. Even larger tumors may behave very smoothly during the operation, and very much slower tumors of let's say 4 centimeters, but with a very difficult interference with the lung, with the mediastinal, with the nerves, may be candidates to watch carefully what you do during the operation. And by the way, sometimes you find during the first exploration one spillage only, and you have a stage 4A. You would never know with the sternotomy, because you would never see. So thoracoscopy, minimal invasive approach is good, and 8 centimeters, yes, is of course large. Sometimes 6 and 7 centimeters are also large.
So the better to call this not large tumors, but advanced tumors.
Yes.
Sometimes it's small, but it invades the pericardium, something like
Yes,
that.
yes.
Thank you.
So thank you very much. That was a good discussion and lunchtime.